Goodwin and I. So today, Emily Goodwin and I will be presenting on type 2 diabetes, including a guideline and cardiovascular update. We have no financial relationships to disclose. For this presentation, I'll be discussing the guideline recommendations from 3 guidelines, the first being the joint guidelines of the American Diabetes Association and European Association of the Study of Diabetes. Secondly, the joint American Association of Clinical Endocrinologists and the American College of Endocrinology. And then lastly, the American College of Cardiology guidelines for cardiovascular risk reduction in patients with diabetes. Emily will be reviewing the cardiovascular outcome trial data of the current medications with proven cardiovascular benefit, and then I'll be giving a very brief overview of continuous glucose monitors. So first, we wanted to start with some diabetes statistics on a national and state level and how it impacts the healthcare system. According to the CDC, over 34 million adults had diabetes in 2018, and 7.3 of those adults, 7.3 million of those accounted for undiagnosed diabetes, and an estimated 88 million adults that were over the age of 18 had prediabetes in 2018. The biggest risk factors for diabetes-related complications were obesity and hypertension, followed by the patient's A1C value, so the higher the A1C value being associated with more complications. And then other complications included hyperlipidemia, physical inactivity, and smoking. As we go through the guidelines for the recommended diabetes medications, you'll see that the guidelines and medications now target these complications rather than just glucose or A1C lowering. In 2016, a total of 16 million emergency department visits were reported with diabetes as any listed diagnosis, including 235,000 with hypoglycemia and 224,000 with hyperglycemia. Also, out of 7.8 million hospital discharges where diabetes was a listed diagnosis, 1.7 million of these were related to cardiovascular diseases, and 130,000 for lower extremity amputations. Other common causes included hyper and hypoglycemia. The total direct and indirect estimated cost of diabetes, diagnosed diabetes in 2017 was $327 billion. And in the table, you can see the increase in direct and indirect costs from 2012 to 2017, as diabetes prevalence also increased from 8.1% in 2012 to 9.4% in 2016. The associated cost of diabetes has also increased. Looking a little closer to home, the Tennessee Department of Health Diabetes Action Report has diabetes listed as the 7th leading cause of death in the state. About 13% of adults in Tennessee have diabetes, with another estimated 250,000 that have undiagnosed diabetes. All counties in Tennessee have a 3-year prevalence estimate higher than the national median, and the total cost for diabetes-related medical claims from TennCare in 2017 was over $260 million. So moving along into the guidelines, the recent American Diabetes Association and European Association for the Study of Diabetes consensus statement declares that the goals of care for our diabetic patients are to prevent complications, both micro and macrovascular, and to optimize the patient's quality of life. So this is to be done using a patient-centered, individualized approach based on patient preference and clinical comorbidities. Shared decision-making is a really important part of this. component in creating a management plan for diabetes. And important considerations with this are using the SMART goals in the bottom box, and then the presence of comorbidities, treatment goals, treatment cost, and insurance coverage. Lastly, the last part of this cycle is ongoing clinical monitoring and support for these patients. In order to achieve these two main goals is very important. The recommendation further expresses the importance of lifestyle modifications and diabetes self-management and education as important parts to success for achieving these goals of care. In considering everything from the previous slide, the ADA and EASD provide an overall approach to glucose lowering algorithm with first-line therapy consisting of metformin and comprehensive lifestyle changes. This algorithm provides guidance for selection of medication based on patient comorbidities such as ASCVD, heart failure, or chronic kidney disease, the risk for hypoglycemia, need for minimizing weight gain or need for weight loss, and if cost is a major issue. There are two things real quick on this slide that I want to point out before going into each of these 5 components separately. Above the ASCVD and heart failure or chronic kidney disease sections, it does say to consider these independent of the A1C target or baseline A1C. So this is an update from last year's algorithm that even patients who are at their A1C goal, we should be adding these agents that have additional benefit in the diabetic population for these specific comorbidities. And I also think it's really important to note in the top right corner in the blue circle that to avoid clinical inertia, it recommends to reassess and modify therapy regularly, which is every 3 months. And this is one thing outpatient we're trying to push for more, is closer follow-up for these uncontrolled diabetic patients and actively managing and titrating medications even as often as every 2 weeks until they're more controlled. When starting to look at the indications for medications, we know that microvascular complications can be mitigated by maintaining normoglycemia, but we have seen that the risk for macrovascular complications is independent of glycemic control. And since diabetes patients are at such high risk for macrovascular complications, the guidelines and drug companies have really focused on decreasing these risks with medications as much as possible. So looking at the first column with the ASCVD, established or high-risk patients with a high ASCVD risk, the ADA guidelines recommend either a GLP with proven cardiovascular disease benefit or an SGLT2 with proven cardiovascular disease benefit if the GFR is adequate to use one of those agents. The GLP agents with an FDA-labeled indication for cardiovascular disease benefit are Liraglutide, Semaglutide, and Dulaglutide, or Victoza, Ozempic, and Trulicity. And the SGLT2 agents with proven cardiovascular disease benefit are Empagliflozin, Canagliflozin, and Dapagliflozin, or Jardiance, Invokana, and Farxiga. On the right side of this algorithm is the guidance for patients where heart failure with reduced ejection fraction or chronic kidney disease predominates, and SGLT2 with evidence in reducing heart failure and or chronic kidney disease progression is recommended as long as the GFR is adequate, and if patients are intolerant to an SGLT2 or an SGLT2 is contraindicated, then it recommends using a GLP-1 with proven cardiovascular disease benefit. Both of these algorithms, the choice in agent of which to add to metformin is really heavily dependent on avoidance of side effects, particularly hypoglycemia and weight gain. And then cost and patient preference is important to take into consideration. And later, Emily will be covering more in depth of like the cardiovascular outcome trials for each of these agents. The next section involves choosing an agent if there's a need to minimize hypoglycemia, so usually in our brittle diabetic patients or patients with low bowel glucose or elderly patients is where this would really, those patients would fall into this category. The ADA guidelines state here that it's appropriate to use any of the agents listed in from the top 4 classes, so a DPP-4, GLP, SGLT2, or thiazolidinedione, as all of these carry a low risk of hypoglycemia as monotherapy. Ultimately, the goal is to attempt to avoid insulin or sulfonylurea if hypoglycemia is a major concern. And the preference out of the 4 classes would go to either a GLP or SGLT2, as these have additional benefits outside of just solely lowering the blood glucose or A1C value. In patients without ASCVD or heart failure or chronic kidney disease where weight loss or minimizing weight gain is the main focus for the patient, a GLP with good efficacy for weight loss or an SGLT2 is recommended. Weight loss or minimizing weight gain is an important goal for all of our diabetic patients to delay insulin resistance. So the hierarchy that I have here listed for the GLP-1 class for weight loss is semaglutide or Ozempic, providing the most weight loss, followed by liraglutide or Victoza, and dulaglutide or Trulicity. And then the bottom 3, the extended release exenatide or Bydureon, immediate release exenatide or Byetta, and lastly lixisenatide, which is Adlexin. This hierarchy for weight loss is very similar to the hierarchy for the degree of A1C lowering within the GLP class, with the 3 agents on top providing the most A1C lowering compared to the 3 agents listed on the bottom. Also remembering that the first 3 agents on top have indications for risk reduction in major cardiovascular events in diabetic patients with established or high risk for cardiovascular disease, whereas the last 3 agents do not. Liraglutide also has an FDA indication for treatment of obesity, and it's branded under the name Saxenda. These guidelines also suggest using implementing strategies for weight loss, which can be done via surgical and non-surgical options. Non-surgical options would be lifestyle modifications and use of other medications that cause weight loss, and then surgical options being bariatric surgery, which has become an increasingly popular recommendation. The last part of this algorithm is guidance with which agents to choose if cost is a major issue independent of patient comorbidities. So Metformin is the first-line agent, and the immediate release formulation is available at no cost. It is free on the free medications list at Publix for patients with or without insurance. So every type 2 diabetic patient should be on Metformin unless it's contraindicated or they can't tolerate it because of gastrointestinal reasons. The next cheapest alternative agents for add-on therapy would include sulfonylureas and thiazolidinediones, as long as the patient doesn't have a contraindication to using one of these classes. These medications, however, don't provide any additional benefit to the patient other than blood glucose lowering and A1C lowering, so no cardiovascular benefit. I also briefly wanted to mention here TennCare, the 340B program, and manufacturer coupons. TennCare has a published preferred drug list formulary with diabetic medications from all classes that are on their preferred drug list, so patients who have TennCare can get Victoza or an SGLT2 for their $3 copay. Also, we have the 340B program, which some of the first-line medications are on too that might assist in a patient getting started while prior authorizations or patient assistance forms are completed. And then most of the newer agents have manufacturer coupons that allow for discounted medications for patients that have commercial insurance. The American Association of Clinical Endocrinologists and the American College of Endocrinology glycemic control algorithm, like the ADA and EASD, recommend lifestyle changes and ongoing glucose monitoring, ideally with a CGM or continuous glucose monitor. It also recommends to assess for established or high ASCVD risk or chronic kidney disease, independent of glycemic control, and to use an SGLT2 or GLP in those patients. So both algorithms provide a step-based approach to medical management for patients with type 2 diabetes, and this algorithm gives a little bit more guidance for when to add on or initiate dual or triple therapy with a newly diagnosed diabetic patient based on their entry A1C value. For example, in the middle two columns, it recommends initial dual therapy for an entry A1C value of greater than or equal to 7.5%, with metformin being a first-line agent, with metformin and then adding a first-line agent such as a GLP or SGLT2, and then to step up to triple therapy if they're not controlled after 3 months. The order of medication classes listed in each box represents the suggested hierarchy for use, and the length of the teal line underneath each medication class reflects the strength of recommendation. So the only 3 drugs that have a strong recommendation are metformin, GLPs, and SGLT2s. Of note, you will see in between each of the mono, dual, and triple therapy boxes, it does recommend to step up therapy every 3 months. This reevaluation at the 3-month mark is similar to what the ADA and EASD recommends and provides closer follow-up and ability to assess if the patients can obtain their prescribed medications, assess compliance with diet and lifestyle modifications and their difference in their A1C, and if they need an additional agent. The third and last guideline we'll look at is the American College of Cardiology Guidelines, Consensus Decision Pathway on Novel Therapies for Cardiovascular Risk Reduction in Patients with Type 2 Diabetes. This was recently updated in July of this year. I wanted to mention these guidelines to further support the realization that diabetes is no longer only focused on decreasing the blood glucose value and the A1C. While that's still an extremely important part of diabetes management, the focus has really shifted to decreasing these risks of the associated comorbidities with diabetes. So other specialties outside of primary care and endocrinology are now focusing on the importance of decreasing these macrovascular complications. And since cardiovascular disease is one of the leading causes of morbidity and mortality with diabetic patients, it makes sense for the cardiology guidelines to reflect these recommendations and to modify risk in their diabetic and non-diabetic patient population. So this slide is just the overview algorithm from the ACC. It's very similar to the previous 2 algorithms that we looked at for patients with established or high risk ASCVD, heart failure, and DKD, which in this guideline is diabetic kidney disease or chronic kidney disease, so the same as the previous 2. And it recommends SGLT2s and GLPs with proven cardiovascular benefit in addition to metformin and lifestyle changes. These next 2 slides are really here for more completeness. They are the pathways for use of SGLT2 or GLP in the cardiology guidelines that are the same for the previous 2 that we already talked about. That's the GLP. So to wrap up this first section with a self-assessment question, what are the first-line diabetes medication classes? Anybody? So all of those metformin, GLPs, and SGLT2s are all considered first-line medications. So now I'm going to turn it over to Emily to talk about the cardiovascular outcome trial data. I'm going to take.
Thank you, Lacey, and thank you all for being here. As Lacey mentioned, I am going to be talking about some of the key literature that's come out in the past few years. This has been a very prominent topic in pharmacy right now, and as she presented earlier, the statistics really help us see that this problem is very profound. It has a great impact not only on people right here in Tennessee, but the whole country, and the problem is not getting any smaller. We're seeing increasing number of patients with diabetes and increasing costs for these complications. And so I think it is very important to dive into some of this literature and to really determine what are the outcomes that we're looking at, what is the benefit that we're providing to some of these patients by prescribing these medications. So here's a timeline of all of the trials that have come out. Most of them are out at this point in time. But dating back to 2013, we started seeing a lot of these trials come out, and this was based on an FDA mandate that all currently available diabetic medications need to be evaluated for cardiac safety. Statistics have shown that 75% of diabetic patients greater than the age of 60 will die of an embolic event, either an MI or a CVA. So this further stresses the importance of this data, not only in treating the A1C, but then targeting some of these cardiovascular outcomes that we know are exponentially higher in these patients with diabetes. Most of these trials have had very similar primary outcomes in the form of a 3-point MACE, and so I wanted to discuss that for just a little bit. You'll see very common themes throughout these. The 3-point MACE primary outcome consists of cardiovascular death, non-fatal MI, and non-fatal strokes. Secondary outcomes in many of these trials included heart failure hospitalizations, unstable angina, and other renal outcomes. And in order for these drugs to maintain their labeled indication for the treatment of type 2 diabetes, they must at least show cardiac neutrality, meaning that they are no worse than placebo. They don't increase the risk of cardiovascular complications. So talk about metformin first, as it is still considered pretty much our first-line agent for most patients with type 2 diabetes. I'm sure you guys learned in school, as I did. It's widely accepted that metformin carries cardiovascular benefit labeling and improves mortality. I want to bring attention to the fact, though, that there are no robust trials comparing cardiovascular outcomes with metformin to other things that we would now consider standard of care. The UK PDS trial is probably the best data that we have for metformin, and it came out in the late 90s. But still used pretty much to give metformin its mortality benefiting qualifications. So it compared metformin to conventional therapy, which at the time was lifestyle modifications, diet and exercise, or intensive therapy, which they considered either sulfonylureas or insulin therapy. And they did see a cardiovascular benefit with metformin, especially compared to conventional therapy. And we know from monitoring these patients inpatient and outpatient over the years that it is very difficult for many of these patients to decrease and maintain a normoglycemia and a normal A1C with just conventional therapy. And so the benefit with metformin, while it is there compared to essentially doing not much, is probably not as robust as some of the trials coming out later. And all of the trials that I will discuss further consider metformin to be standard of care. So these benefits are in addition to the use of metformin. We talk about GLP-1s, or glucagon-like peptide-1 receptor agonist. Glucagon-like peptide-1 is synthesized in the small intestines. It stimulates glucose-dependent insulin secretion, decreases glucagon secretion, and slows gastric emptying, which improves satiety and does promote weight loss. The A1C lowering is relatively good for an add-on agent that's not insulin. It's at 0.5 to 1.5%. We have a couple different dosing mechanisms depending on the medication that we choose. And so we can either target more prandial glucose or prandial and fasting with some of our longer-acting agents. There's a low risk of hypoglycemia, especially when these are used as monotherapy or in addition to metformin. We do use caution when we're adding them onto either sulfonylurea or insulin therapy. Some doses might need to be adjusted to avoid the risk of hypoglycemia. Most of the adverse effects throughout this class are related to GI side effects, and there is potentially an increased risk of pancreatitis. So something to be aware of if your patient has experienced significant pancreatitis or is at a high risk. This might be a reason to avoid these or withhold starting them and modifying any other risk factors that can be modified prior. So we'll talk about these 3 agents that all carry labeled indications for decreasing the risk of cardiovascular death. As you can see, liraglutide is dosed once daily, and semaglutide and dulaglutide are dosed weekly. The names of the trials are here, but we'll talk about each one individually. And I think it's very important to note that all of these carry a very similar labeled indication for the decreased risk of cardiovascular outcomes. But as you'll see, if we dig down deeper past that first primary composite outcome, that we're not always offering the same benefit based on the drug that we choose. And so that is something to be aware of. And so if a provider asks or a patient asks, that we're able to explain to them exactly what the trials did show. So liraglutide versus placebo looked at patients with type 2 diabetes at a high risk of cardiovascular disease. They could be on other oral medications or insulin. All of the patients were at least 50 years old with cardiovascular disease or older patients with pre-existing risk factors. Like I said, the outcome included the 3-point MACE was the primary. It was cardiovascular death, non-fatal MI, and non-fatal stroke. And we did see a decrease of the cardiovascular outcome in the liraglutide group at 13% versus 14.9%, which was deemed to be superior. And that difference, if you break down the composite outcome, was driven by a decreased rates of cardiovascular death. There were similar but non-significant decreases in rates of non-fatal MIs and non-fatal strokes. Other benefits were seen throughout the trial as far as weight loss, decreased systolic blood pressure, and decreased rates of nephropathy in the liraglutide group. Most of the adverse events were related to GI side effects, and they also noted a non-significant increase in malignant or benign neoplasms and acute gallstone disease. These are mainly class-wide effects for these. The semaglutide versus placebo or SUSTAIN-6 trial was set up very similarly to the LEADER trial with the same primary composite outcome. It was superior to, semaglutide was superior to placebo at 6.6% of patients experiencing the primary outcome versus 8.9%. But in this trial, the significance or superiority was deemed to be due to a significant decrease in non-fatal strokes. We did not see a significant decrease in the rates of MIs, and there was really no difference in cardiovascular death rates between the 2 groups, semaglutide versus placebo. As far as other benefits, they were very similar to the liraglutide group. In this trial in particular, we did see a significant increase in the risk of retinopathy in the semaglutide group, which we think is due to the rapid decrease of A1C. This is probably a class-wide effect, as many of the other trials have noted non-significant increases in retinopathy, but semaglutide is one of the more potent agents, and this trial did find a significant increase. And then more patients did discontinue due to GI side effects. And then our last GLP-1 that we'll be discussing is dulaglutide, and this is the REWIND trial. It came out most recently in very similar patient population, usually 50 years or older with established cardiovascular disease or 60 years or older with risk factors. The same composite outcome was experienced less in the dulaglutide group at 12% versus 13.4% in the placebo group, which was also deemed to be superior. And this was also driven by a reduction in non-fatal strokes. No difference in rates of MIs or cardiovascular death. And very similar outcomes other than the primary. So our next class of medications is SGLT2 inhibitors, or sodium glucose cotransport 2 inhibitors. Their A1C lowering potential is about 0.5 to 1%, and we'll be talking about the 3 listed below: empagliflozin, dapagliflozin, and canagliflozin. Their mechanism of action is through increasing urinary excretion of of glucose through, sorry, through the proximal convoluted tubule. This can also decrease blood pressure and promote weight loss, and if you're thinking about diuretic effects, this makes a lot of sense. We're using these as to diurese people and keep volume off. And these have also been shown to convey some renal benefits that we will discuss. There are some cautions with these. Unlike the GLP-1s that do not have any renal adjustments, these are going through the proximal convoluted tubule and do need to be renally adjusted. And we do have creatinine clearance cutoffs for these medications, so something to be aware of. We have seen more dehydration and subsequently hypotension because of the diuretic effect of these medications. Trials have also noted recurrent urinary tract infections and mycotic genital infections as some of the side effects. Slightly increased LDL levels have been noted, but one of our main adverse effects that we have been seeing more frequently is euglycemic DKA. So I'd encourage anybody, if you have a patient coming through the emergency department, their labs sort of are mimicking DKA, but their glucose is normal, check their medication list and see if they're on an SGLT2, because that might key you into the cause of euglycemic DKA. And then the FDA has put out a warning for rare but potentially fatal Fournier's gangrene with the use of SGLT2s. The Empagliflozin trial that looked at cardiovascular outcomes in diabetic patients was called the EMPA-REG trial. It looked at type 2 diabetic patients with high risk or established cardiovascular disease, much like the others in the GLP-1 class. The same composite outcome of cardiovascular death, non-fatal MI, and stroke. And we did see superiority in the empagliflozin group, but this was driven by a reduction in cardiovascular death. It was proven to be non-inferior for hospitalizations for heart failure and unstable angina, for hospitalization, and then a significant decrease in heart failure-specific hospitalizations and significant reduction in death from any cause. So because of these decreases in hospitalizations for heart failure and renal outcomes, the EMPEROR trial was just published a few months ago, and they looked specifically at patients with diagnosis of heart failure, either class 2, 3, or 4, with an ejection fraction of less than or equal to 40%. And these patients all were given either empagliflozin or placebo in addition to a standard of care. They had different NT-proBNP cutoffs that varied depending on the severity of disease, and this is important because we'll contrast that with the Dapa-HF trial in a few minutes. They were primarily looking at heart failure hospitalizations and cardiovascular death, and of note, these patients did not have to have diabetes. Less than half of them in the EMPEROR and in the Dapa-HF had a diagnosis of diabetes at the start of the trial. So we saw a decrease in the rates of heart failure hospitalizations, 19.4% versus 24.7% in the placebo group. And the significant outcome was driven by a decrease in heart failure hospitalizations, not by decreased cardiovascular death. We also saw a significant decrease in the rate of decline of eGFR, so patients that were started on empagliflozin had less reduction of their creatinine clearance or the eGFR throughout the trial. And the main adverse effect from the drug was considered to be uncomplicated genital tract infections. Dapagliflozin was also studied by itself as far as a type 2 diabetic medication in the DECLARE TIMI 58 trial. Very similar patient population, and it was proved to be non-inferior for the primary outcome, but they did see a decreased rate of heart failure hospitalizations and very similar renal outcomes, which led to the Dapa-HF trial, which also looked at patients specifically with heart failure, and less than half of these patients had diabetes. So the primary composite outcome for worsening of heart failure or cardiovascular death, dapagliflozin was superior in these patients. And this finding was similar when we separated out diabetic and non-diabetic patients. As far as safety outcomes, rates of volume depletion and renal outcomes, they were very similar between the two groups, so it did not seem to be increasing risk for these patients. And then lastly, canagliflozin was studied in the CANVAS trial. Once again, very similar patient population and primary outcome. canagliflozin was shown to be superior, but each of the individual components in this trial were not significant. The significance came from combining all of the outcomes together. Secondary outcomes, death from any cause, cardiovascular death, progression of albuminuria, composite of cardiovascular death or heart failure hospitalizations, did not show a difference in death or decrease in heart failure hospitalizations, but it did show a decrease in progression of albuminuria and substantive loss of kidney disease. And there is a note on here, increased risk of fracture and amputation, which I'll address in just a second. But the renal outcomes of this trial led the investigators to do the Credence trial, which looked specifically at patients with an eGFR between 30 to less than 90 mils per minute albuminuria, and they had to be on an ACE or an ARB. And as far as renal outcomes with canagliflozin, canagliflozin was superior to placebo as far as lowering the rates of renal outcomes. And in this trial, they did show no difference in rates of amputation or fracture. So if you've been following along for a while, canagliflozin used to have a black box warning for increased risk of amputations. That has now been removed, and we no longer consider that to be either a class-wide effect or an effect of canagliflozin. So here's a summary of all of these trials, and like I mentioned earlier, I think it's very important to go past just the primary outcome. Most of these have composite outcomes that are broken down, and depending on what the patient's comorbidities are, what sort of cardiovascular events they've either experienced in the past or might be at high risk of, trying to determine which agent might be the best for them. Obviously, we have to take into consideration cost, affordability, other things, but they're not, even though they all carry a labeled indication for the decrease, for the reduction in risk of cardiovascular outcomes, they might not all be equal for each individual patient. So something to consider when you're making a decision, especially for outpatients, when we're not worried about like a formulary or something. So with that, I will finish with this patient case and then let Lacey come back up and finish. So we have a 58-year-old female with a past medical history of type 2 diabetes. Her A1C is 8.9 at this visit. She has a reduced ejection fraction of 35%. On her last echo, she has coronary artery disease, status post-MI, recurrent yeast infections, COPD, positive tobacco use for 20 years, hypertension, hyperlipidemia, and CKD with a creatinine clearance of about 25 mils per minute. Her current medications are listed. She's on insulin, metoprolol, Lasix, lisinopril, Spiriva, and atorvastatin. So what medication, considering her uncontrolled A1C today, would be the most appropriate add-on therapy for her diabetes and heart history? Anybody? Yes. GLP-1 would probably be best for her, considering she does have creatinine clearance of about 25, so that would exclude her from adding an SGLT2 at this time, and her significant cardiovascular history would indicate a GLP-1 would be a good choice for her. All right.
So lastly, I'm going to give a quick overview of continuous glucose monitors as they're becoming an increasingly popular amongst our patients with type 2 diabetes. So I'll give a quick overview of who should use them and what the benefits are and the availability. I think it's important to know that a lot of the studies that have been done with these have been done in patients with type 1 diabetes, and some patients, there are some trials with pregnant patients. So just keep that in mind. We don't have a whole lot of information on use in type 2 diabetes, but it is becoming a more important part of type 2 diabetes care, and one of the guidelines even recommending now to use CGMs for blood glucose monitoring. So patients that would benefit from a CGM would be patients that have to regularly self-monitor their glucose, so patients that are doing finger sticks 3 to 4 times a day, patients with frequent hypoglycemia, especially those with hypoglycemia unawareness, patients with significant glucose variability or labile blood sugars that may have readings that are extremely high or extremely low throughout the day with no identifiable pattern. And then lastly, patients who have an A1C above goal. So these devices may also be of benefit if we have difficulty obtaining blood glucose logs from patients, which is a frequent limitation we run into outpatients. So the benefits of CGMs consistently seen in the studies are that they decrease A1C values and reduce hypoglycemia episodes. And this is really due to the availability of these devices to have alerts for active or impending hypoglycemic episodes. So it will have an alarm that will set off that will alert the patient that you're either trending towards a hypoglycemic episode or you are hypoglycemic. It's important to note that with the STAR3 trial, it did not show an improvement in overall quality of life, which was something I was surprised at first because you would think it would be a lot easier for patients, but I think you'll understand based on which device they use that may change. Some factors that affect the above benefits include the amount of time the continuous glucose monitor is worn. So if it's worn less than 70% of the time, it did not result in much or any improvement in A1C. The patient's age and education level need to be taken into consideration, and the type of device, like I just mentioned, is really important, as some are more labor intensive than others. And then also patients that had early success with gaining control of their blood glucose in the first month of use were more likely to continue use for the next 6 months. So currently, continuous glucose monitors are only available with a prescription, and most insurances will cover some of the costs with a prior authorization. As a part of the COVID pandemic, they're more readily available for the true Medicare A and B patients, as during this time they've kind of relaxed their requirements, and you don't have to prove now that you're monitoring 3 or 4 times a day and have multiple daily insulin injections. So that's been a positive. So I have listed here the available continuous glucose monitors. You'll notice they're separated into professional and personal use, with the main difference being with use of the professional monitors, the user is blinded to the blood glucose reading. Therefore, they still have to rely on their finger sticks to manage for therapy decisions. So in the second column is the age that the devices are approved for. The Dexcom, as you can see, is approved, can be used in patients as young as 2 years old. And the sensor life in the next column for the devices vary based from 6 days all the way up to 90 days. And probably the most important column is the last one, where it talks about the calibration requirement. This is probably most likely why they found no improvement in quality of life. So some of these require calibration twice a day, so patients are still using finger sticks twice a day with their CGM. So it's not surprising with some of those devices you would not see an improvement in quality of life. But I would say from experience with the ones that do not require calibration, like the Freestyle Libre or the Dexcom, that quality of life is improved. So this is just an example of a reading from a Freestyle Libre professional CGM. This is actually one of our clinic patients. The first one, you can see their average glucose reading for the time that the sensor is worn is 318. And the middle bar graph gives the time in range, and in this patient's case, they were above 180 99% of the time. And in visit 4, you can see that the average glucose readings drastically decrease, as evidenced by the patient being in target range 84% of the time. And the graphs at the bottom showing that most of those readings at visit 4 were within that target range, as opposed to the first graph where almost no readings were in the target range. These systems also give daily readings, similar to these graphs at the bottom, just split up into each day that the sensor is worn. So next, a little bit more in depth on time and therapeutic range. For patients that have a CGM, you can set a different target range. So if you want the lower end to be a little higher in your patients that you're worried about hypoglycemia, you can set it to 80 or 100. The graphs for time and therapeutic range really seem to help the patients understand how often they're not in their ideal blood glucose range and give them a visual to work off of. The table on the right shows that as a patient's time in therapeutic range of 70 to 180 increases, there's an overall lower association with a lower A1C. So each 10% increase in time in therapeutic range is associated with about a 0.8 decrease in A1C. These next two slides are just something to take into consideration when assessing a patient's A1C value. So these are two separate patients that both have an A1C value of 6.7%, but the coefficient of variation is very different between the two. So stable glucose levels are defined as a coefficient of variation of less than 36%. And the coefficient of variation is easily recognized with information that we get from continuous glucose monitors, and you may miss if you only have a single blood sugar reading from a patient. So looking at the second graph, and to help decrease the overall coefficient of variation for that patient. This is one of my favorite tables that shows the contribution of fasting and prandial glucose to the overall A1C value. Although this is from a smaller study, I think it brings to light that the split that we were taught in school of 50-50 for basal bolus may not hold true, especially the higher the A1C value. So for example, patients that have an A1C value over 10, which is not too uncommon that we see that, the patients may require a higher basal dosing to get an overall decrease in the baseline blood glucose, whereas so 70% would be from fasting and 30% would be from prandial. So lastly, this is just a patient case to show you how complex diabetes management can be with the information that the patients get from a continuous glucose monitor. They get a lot more information than just a reading on a blood glucose meter. So in addition to the glucose value of like 265, they're also provided with a trend arrow. So this is actually what's shown on the screen for Freestyle Libre. So if their blood sugar is trending up or trending down, you can see like a rapid increase, increase, stable, decrease, rapid, decrease, so that they have an idea of where their sugar is going. Each system has different categories of trend arrows and different correction factors that are specific to the systems and the patient. So in this case, the patient is about to eat a meal containing of 60 carbs, and her home regimen is to give 1 unit of insulin per 10 grams of carbs. So that's So just based on what she's going to eat, she would be giving 6 units. Now she gets a correction factor for every 1 unit above for every 30. She gives herself 1 unit for every 30 above 120. So it's currently at 265. So that would be around 4.8 units for that. And then based off of her trend arrow, which is increasing, she would give an additional 1.5 units. So all 3 of those 6, 4.8, and 1.5 together, she would give herself 12 units based on her reading, her trend arrow, and what she's about to eat. So I just wanted to put this in there to show how that you can get a lot of information from one reading from the continuous glucose monitor that we can't get from the others, and can lead to better management of glucose. So in conclusion, the guidelines focus on a patient-centered, individualized approach, taking into consideration the patient's A1C, but most importantly, the patient's comorbidities. They continue to focus on diet and lifestyle modifications, reassessing and modifying treatment more frequently, every 3 to 6 months at least. Our agents with cardiovascular benefit in our diabetic population are the GLP and SGLT2 class, with some information that the SGLT2 class has benefit outside of the diabetic population. And then lastly, that continuous glucose monitors provide us with previously unobtainable glucose information and trends in which we can make targeted medication therapy decisions based on the information that we have. This concludes our presentation. Does anyone have any questions for me or Emily?
So where does insulin now fall in management of diabetes? It's like, a long time ago, it was Metformin, okay, insulin. Now it seems like you need to add quite a few more medications on?
Yes. So the question is, where does insulin fall in management of type 2 diabetes? Which is a great question. Based on the patient's A1C, if their A1C is still over 9, you would still consider insulin, but you would consider it with other first-line medications. So I would, if it's like a new diagnosis, they would get metformin, a GLP or a SGLT2, and insulin. Yes.
I remember reading a trial talking about oral GLP-1 agents. Has that been evaluated in what place of the therapy?
Yeah.
So semaglutide does have an oral formulation that's available. We're looking at.
Speak to the mic.
Oh, yeah. Repeat the question. So the question was, is there an oral formulation of a GLP-1? And the answer is yes, there is. Semaglutide has been approved in an oral formulation. The brand name is Rybelsus. But when looking at cardiovascular outcomes data, it has been shown non-inferior to placebo, but it does not have the same cardiovascular benefit as injectable semaglutide. So in patients that are adamantly opposed to an injectable agent, it is reasonable to add it on. But if your patient is willing, you will probably get more cardiovascular benefit based on the data that we have currently with a subcutaneous injection.
I had a question to follow up on that. I think you mentioned semaglutide and retinopathy due to the rate of aggressive blood glucose lowering. Is there a way that you found to kind of combat that or prevent that, like a slow titration?
So the question is about retinopathy with the injectable semaglutide. No, there's not a way to combat that. It's actually seen with insulin too. Patients that go from an A1C of 14 to 7 when you start them on insulin also have that risk of retinopathy too. So it's really just with the semaglutide being the most potent one, we see it more with that one, and with insulin, which isn't really talked about, but it does happen with it too.
So the guidelines do still recommend at least once yearly monitoring for these patients, as they always have. So that's the only, just watch for it.
So I really liked the continuous glucose section. Are they doing any studies in patients using those devices?
Yeah, so the question is about, are you talking about specifically in type 2 diabetes or just in general? About studies with continuous glucose monitors, yes, there's been a lot of data that's come out in the last year or so with that. We actually did a study in clinic about it, using it in type 2 uncontrolled diabetic patient populations. There's a lot of trials that have come out for controlled type 2 diabetic patients, which doesn't fit a lot of our patient population that we see. So it is any like diabetes technology journal or whatever is covered up with trials on the continuous glucose monitor. I really think it'll become almost standard of care in the next few years.
Is anybody looking at it for inpatient use? So instead of us doing active checks on our patients using one of these devices, not for the patient to use, but for us?
Yeah, so the question is about use for inpatient. I have seen one or two things about using it inpatient, especially with the COVID pandemic on patients that tried to decrease the amount of face-to-face contact where they can check their own instead of having to go in for Q1 hour AccuChecks if they're on a drip or something. It's very small, like pilot studies so far with it. There's not a whole lot of data on inpatient use yet, but I could see that becoming something we see too.
I have one more question. The professional use continuous glucose monitor, where would a role for that be where you think doesn't alert the patient?
Yeah, so the question is about the role of professional continuous glucose monitors. That is what we did our study with in clinic, and I can tell you from experience, patients were not as excited to use them because they couldn't actually scan and get an immediate read. They were still having to monitor on their own. So I haven't seen them used very much at all other than like in a study. Usually any patient, we would get them their personal one to have access and hopefully increase their quality of life, as getting a actual log of blood sugars is probably one of the hardest things to get from this patient population in order to make therapy decisions off of. So we don't use them routinely. I've seen them more in studies, but definitely trying to get patients like the personal one that they can actually make therapy decisions off of it more instantaneously. Anyone else?
In your clinic, you were talking about the type 2 patients and all that being a lovely compliance group, but these agents are bombarded America every evening in the nightly news with these patients on. How good are these companies about helping out patients long term? Because this is not just a 6-month thing and we're done. How long are you seeing these companies provide support for these patients long term, or what do you say on that?
Yeah, so the question is about support from the manufacturers for these expensive new GLPs and SGLT2s. For the most part, insurances are starting to cover them fairly well. As far as the manufacturer help, they have pretty good patient assistance programs for uninsured, or one of them actually has medication assistance for when the patient's in the donut hole, which is a first of what I've seen for patient assistance. The discount coupons are pretty good as far as some of them have like $20 copay for a year, but then that usually does run out after the year time frame. and it is only good for commercial insurance and not for Medicare or TennCare. As far as TennCare, they're covered. Their $3 brand copay for Victoza, and I think all of the SGLT2s are on the Victoza or Bydureon, and then the SGLT2s are also on their preferred drug list. You have to do a prior authorization, but they can get access to them. All right. Thank you all. I don't know. I think someone's on. Do you want to? Travis?